So what we're going to be talking about is something called the Certified Mental Health Assistant, a brand new thing that we are creating here in the state of Ohio. Doesn't exist anywhere else. And so we're going to take today to kind of talk about it, get some ideas, discuss the purpose of it, and just to inform you of what's going on. So disclosure here, I helped create this idea. I am the program director. So I think it's an amazing idea. Not everyone agrees with me, but I'm hoping by the end of the next 40 minutes or so, you all will agree with me as well, that this is an amazing idea and something that's really important. So how we're going to divide up the talk is into the problem that we're trying to address. Solutions that are good, they're good ideas, they just won't work. And then what we think is the innovative solution that will. And the problem starts with something that you all are very aware of, which is the increasing rates of mental illness among Ohioans. This is mental illness in Ohio adult 2020 to 2023, steadily increasing up to the point of about 1 in 4 Ohioans having a diagnosable mental illness. This is the rate of substance use disorder 2020 to 2023. Just actually yesterday, I got an article that talks about alcohol-induced deaths, and between 2019 and 2024, alcohol-related deaths in Ohio increased by about 12%. So just in that 5-year period of time, we saw a 12% increase. We are all aware of the opiate overdose problem. So we're just seeing these increased rates of mental illness and substance use disorders. But perhaps the most frightening, for me anyway, the most frightening graph is this one. This is from Health Resources Services Administration, which looks at workforce needs and workforce availability. And this is the slide looking at the national number of psychiatrists. So that little orange line you see going up steadily between 2022 and 2037 is the predicted need for psychiatrists in the United States. This is specifically adult psychiatrists or general psychiatrists, not child psychiatrists. But you see that steady increase on the orange line. The blue line is the actual number of psychiatrists, and it is dropping and falling and hitting a nadir there about 2037. So what that's going to mean is by 2037, the United States will have about 43% of the psychiatrists needed to take care of the mental health needs of the nation. Now, by the way, I'll show some data. They have nurse practitioners and psychiatric PAs as well. This is just looking at the psychiatrists. But as bad as that is, it's actually worse in the state of Ohio. They're predicting that by 2037, the state of Ohio would need about 3,000 psychiatrists. We will just under 3,000, and we will have just over 1,000. So we will be at 35% staff. But again, psychiatrists aren't the only game in town. So we need to look at, well, what if we roll in mental health nurse practitioners? What if we roll in psychiatric physician assistants? What are we looking at then? Well, you see the top line here, the numbers of adult psychiatrists. 2024, they said we needed about 2,200, and we had about 1,100, so we're at 50%, going down to 35%. If you add in mental health nurse practitioners and psychiatric physician assistants, then they're saying last year, 2024, we needed 3,300 and had about 2,230. That by 2037, we're going to need 4,400. And we're going to be about 1,600 providers short. So if you look at all those folks who have received specialized training in prescribing medications for mental illness and substance use disorder, we're going to be 1,600 short in the state of Ohio. That's a problem. And it's already a problem. This is the Ohio Council of Behavioral Health and Family Service Provider. They did a survey of community mental health centers. This was in 2021. And at that point, 99% were already having difficulty finding new clinical and medical staff. 88% were having difficulty retaining staff. 77% were having increased turnover of staff because there are so many openings. You have that situation where the grass is always slightly greener at the other community center. And so people were leaving and bouncing from one agency to another. 91% of them had a position that had been open for 45 days or longer. There just simply aren't enough providers, and we're kind of shifting them around, but there's just not enough. And that's already leading to problems in quality of care and access to care. This is SAMHSA data from 2023. Only 73% of Ohioans who are seeking mental health care were satisfied with access to care and quality of care that they receive, much less than the US average, which is about 88%. So we're having problems with access. We're having problems keeping providers. We're having problems with quality of care. And as there are fewer and fewer psychiatrists over the next decade, it's just going to get worse. There just aren't enough. So I'm going to stop here for a second. And folks either we can chat or preferably go ahead and unmute maybe. Why do you suppose there's this increasing gap between the societal need for psychiatrists and the actual number of psychiatrists? What's contributing? And again, I'm talking mostly psychiatrists because we are seeing increasing numbers of mental health nurse practitioners. We are seeing increased numbers of psychiatric PAs, but it's not keeping up with the loss of psychiatrists. So I'm focused on psychiatrists, but that's why. Why are we seeing that difference between the need and the actual numbers? Any thought?
Could it have to do with pay?
Okay, no, that's a great thought. Is there, so for folks coming out of medical school, maybe there's, it's better to go into a different curriculum. Now we're going to talk about the numbers. Actually, we are seeing larger numbers of psychiatry trainees than we've ever seen before. If you compare it to 15 years ago, we have twice the number of psychiatry residencies and twice the number of psychiatry slots. So there's a lot of interest in psychiatry, but we're still losing ground. But that's a great thought. Maybe other ideas of why that increasing gap?
Well, I'll say on a positive side, we've helped, I think, over time decrease the stigma.
Yeah.
So more people are coming in for care, and it's sort of this balance. How do you increase
Yeah.
the workforce at the same rate as the number of people that are willing to actually seek mental health care?
Yeah. No, I think that's absolutely right. You will see it on one of my slides. That's why. But yeah, we've been telling people if you need help, ask for help. If your friend needs help, get them into help. And people listening to us, people trying to keep up with us. So yeah, so increased demand. Well, part of it's increased in population, right? Just the more people you have, the more you need. That's not the big reason. That's a little reason. The stress on society. I mean, we all experience that every day. The fragmentation of what used to be as solidifying factors, increasing rates of mental illness, decreased stigma. All of those are leading to that increased demand for psychiatry and demand for mental health services. But what about that decreased numbers? Because those numbers are decreasing despite the fact that last year we matched more residents into psychiatry residency training than we've ever matched before, and we'll probably match more next year than we've ever matched before as well. So why is that? Well, I hate to tell you this, and especially because I got some fellow psychiatrists on here, but we're old. Psychiatry is the third oldest profession, not meaning the discipline of psychiatry has been around the third longest. It means the individual people who are in psychiatry. If you average all of our age, we're the third oldest profession. This is AAMC numbers. This is from 2024 or 2023, sorry. At that point, 32% of the psychiatrists in Ohio and 37% of psychiatrists nationwide were 65 years of age and older. So a third of psychiatrists are already in retirement. And that's what the problem is. Yeah, we're training more folks than we've ever trained, but we are just aging out of the profession quicker than they can close that gap. So that is the biggest problem. There's also, and I'd be curious if folks have seen this. I've had some anecdotal stuff, and I could find one reference to it. But also, there seems to be a change in work habits. Right. For the last 15 or 20 years in medical education, we've been emphasizing, wellness and work-life balance and, be in it for the long haul and take care of yourself and don't overstress yourself. And what we're seeing is that they're just not seeing as many patients as they used to. I only could find one study. This is out of Ontario, so it's Canada, not the United States, but I suspect it's pretty similar. Of these 2,000 psychiatrists, 47 had been out of medical school for more than 30 years. So this is an older, half of them are in that 60 above range. And what they found is that recent graduates see fewer patients than older psychiatrists, and that we're seeing more and more women enter psychiatry, which is great. But women as a whole tended to see fewer patients than men did. And so what we're seeing are decreased numbers of psychiatrists, and the replacements that we're getting tend to see fewer patients than what they're used to. So this is all making that gap worse. So that's the problem, right? Well, the solution's easy, of course. If you don't have enough of something, you just go on Amazon and you just buy more psychiatrists, right? Because there's a pool of psychiatrists, I'm sure, sitting out there somewhere. Well, of course, that's not really the possible. So we're going to look at some solutions that we just don't think will work. They're all good ideas. Every one of them that I'm about to present is a great idea, and I absolutely support every one of them, but they're going to be insufficient. And the first is to train more psychiatrists. I've been involved in training psychiatry residents for the last 25 years. I love doing it. It's fun. We could train more. But we already have 11 psychiatry residencies in Ohio. We have a lot. We train 72 new psychiatrists every year. That's 3% of the US total. But training a psychiatrist takes 4 years, and it's about $100,000 per year. When you look at salary, when you look at benefits, when you look at malpractice, all that, it's about $100,000 a year for each resident for 4 years. So it takes about $400,000 to train a psychiatrist. Federal money has dried up, was stabilized in 1996 and really hasn't increased that much since then. The state doesn't have a lot of extra money around to pay for this. So we rely on healthcare systems to come up with more training slots. But if they train a psychiatrist, they're taking a risk because they're having to plunk down $400,000 to train the psychiatrist. And then they run the very real risk that after graduation and after they're board certified, that this psychiatrist chooses to practice in a state that has a mountain or an ocean, right? They just pick up and they leave because the whole country is short of psychiatrists. So every psychiatrist we train in Ohio could work anywhere else in the country that they wanted to go because every place needs psychiatrists. So is this a good idea? Absolutely. Should we be training more psychiatry residents? Absolutely. Is this going to close 1,600 provider gap in the next decade? No. That's a lot of money. No, that's not going to work. Well, the other solution is to rely more on primary care because most primary care docs are sitting around. They don't got enough to do. They're bored. They're hoping patients come in. They're doom scrolling on their phones because there's just not enough work. And they surely would be glad to pick up this extra work from psychiatrists. Obviously, joking, not true at all. Primary care is already busy. In fact, primary care is already managing 60% of the patients with depression and anxiety. They're already doing the bulk of the work. And there's a shortage of primary care physicians. There aren't enough family medicine and internal medicine docs. Now, it's not as short as psychiatry, but it's still, we don't want to give them a whole bunch of extra work. And then primary care providers also include nurse practitioners and PAs, kind of family medicine folks and general folks. Some of them have had a lot of good training in managing mental illness, and some are very uncomfortable in managing mental illness. And to say they are going to make up for the shortage of psychiatrists seems a little questionable, a little risky. Now, we have collaborative care. Collaborative care is a great idea. I've been, the psychiatry consultant to a couple of different family medicine residency programs and stuff. I love doing that. Everyone supports this. The American Psychiatric Association has supported it for a long time. There's good evidence that it helps identify patients, get patients treated more efficiently and effectively. This article that I quoted there touts it as being, cost effective. But my anecdotal experience, and this is just anecdotal, and maybe you all have seen something different, is I've never seen one thrive without external grant funding. I've never seen one that really paid for itself. I think they exist. I think University of Washington has it set up where it's self-supporting and self-funding. But all the ones I've been attached to, they last as long as the external grant money comes in. And so to say this is our solution to the shortage of psychiatrists when it can't support itself financially doesn't seem to be a great idea. We could train more nurse practitioners and more psychiatric physician assistants. Great, fantastic. Let's do that. The problem is they're not tremendously popular career fields for nurse practitioners and PAs. Only less than 7% of nurse practitioners get mental health training. Less than 2% of PAs become psychiatric PAs. Not particularly popular. So we could set up training programs for them. Would folks come? But then the other problem we have in Ohio is that we again run the risk of putting up a program, developing a program, paying for a program, only to have our graduates pick up and leave and go to one of the many states that offer greater scope of practice and more autonomy. 20 some states have more autonomy and scope of practice. And so folks who get trained here might end up working in Missouri or Montana. So could we do that? Should we do that? Great idea. Absolutely. Is that going to close the gap? Maybe not. Well, what about telehealth? We all love telehealth. None of us did telehealth 10 years ago, or very few of us. Now we all do telehealth, right? And telehealth does great. It redistributes resources. My mom lives in a fairly rural part of Pennsylvania. I think all of her medical care is by telehealth. Um, but telehealth doesn't add time to the day. It doesn't add capacity. It redistributes your time. So if you're sitting in the suburb, you can take care of patients who are out in the rural areas or in the downtown urban area. So it redistributes it. But that means for every hour you're seeing a patient in the urban setting from your suburban home, you're not seeing a patient from the suburbs. You're not seeing another patient who could come in. It doesn't add hours to the day. And it's not like we have folks sitting around with a lot of empty spaces that they have nothing to do with. Everyone's full, everyone's busy. Telehealth redistributes it, but it doesn't add capacity. And many individuals with severe mental illness have very limited access. They don't have a high def camera on their phone. They don't have broadband, Wi-Fi, high-speed internet access. One recent study found that 18% of folks in rural Appalachian counties of Ohio have no internet connection in their home. So, some of the people who need it most are unable to benefit from telehealth. So it's a great idea, but not going to solve the problem. So what are we going to do? I've run through a bunch of very good things. I would support any initiative that does any of those things, but it's not going to meet the problem. And part of the problem we thought here as we thought about it is all of those involve doing what we're already doing and hoping it turns out better. We're already training psychiatrists. We're already training mental health nurse practitioners. We're already, using primary care. Let's just keep doing that and someday it'll turn it around. Well, hoping for a better result is not a great strategy. And one thumbnail definition of insanity is doing the same thing over and over and expecting a different result. If this is the system that got us into the problem, this may not be the system that gets us out of the problem. So we thought, you know what? We need to think outside of the box. We need to be a little bit more creative here. And that's where this came from. We're not that creative. We're borrowing it really from the certified anesthesiologist assistant program. Those were first developed in Georgia in the late 1960s. They now exist in about half the states of the United States. And the idea behind the certified anesthesiologist assistant was you could take someone who has a bachelor's degree, give them a 2-year master's degree, and train them to do one very difficult thing, but train them to do it well. And so we took that idea and we said, well, we could create a 2-year master's level training program with an exclusive focus on prescribing medications under a physician's supervision for folks with mental illness and substance use disorders. So that's what the CMHA is. It's actually a master's program, which is called the Master of Science in Mental Health Practice. And if you have that degree, then you can become a certified mental health assistant. Now, I don't know, and I can't see all your faces, but I can feel the lack of being impressed, right? Because we already have mid-level providers. How is this any different than mental health nurse practitioners? How is this any different than a psychiatric PA? I mean, we already have those folks, and we're saying that's not enough. Why is this going to be different? Well, we think there are some things, a couple of things anyway, that make it significantly different. And part of it involves the scope of practice. So by law, the CMHA has an exclusive focus on mental illness, including substance use disorders. The initial diagnosis has to be by a physician. The physician then decides which patients are appropriate for the CMHA to manage, and they have to get ongoing weekly supervision by that physician just for updates and to keep track of the patients. And there are some limitations to the prescribing privileges. CMHAs are not allowed to write for ketamine. They're not allowed to do magic mushrooms. They're not allowed to do cannabis. They're not allowed to do ECT or TMS. I mean, they can do antidepressants. They can do anti-manic agents. They can do antipsychotics. They can do those things, the bread and butter stuff. But the key that I want to focus in on is that part, that a physician has to evaluate the patient and then decides who's appropriate for that patient to see. We all know that if any of us this afternoon had to seek mental health care for us, a family member, a friend, a neighbor, it's a crapshoot. You're going to be calling up people, who's accepting, who's answering their phone, who accepts which insurance, do they accept any insurance at all? How much money do you have to pay out of pocket? And you could have someone who has a fairly mild illness, but a lot of ready cash, who gets hooked up with a psychiatrist in the next month and a half. You could get someone with a very serious illness who can't find anyone except their primary care doctor. to take care of them because they just can't get in anywhere else. And so there's this real random mix of patients going to see a broad variety of providers. But since we have a physician assessment that starts off the program, what we can start to do is create a hierarchy of care. When that physician says, you know what, this patient, fairly straightforward, major depression, single episode, responding to antidepressants, no significant side effects, that can be followed by primary care easily. They will do a great job with that patient. They don't have as much training, but they don't need as much training for this patient. They're doing good fine. This next patient, treatment-resistant schizophrenia with multiple medical problems, that person needs to see a psychiatrist. That person needs the folk with the most amount of training and the most experience. But there's a broad number who could be handled quite well by mid-level providers, including CMHAs. And so the idea is we are going to create a rational system for matching the severity and acuity of the patient's problem with the training and experience of the provider seeing them. They will see the right level. This is going to provide more efficient care because everyone is practicing to the top of their license. The psychiatrist is going to be dealing with the most complicated ones because they have the most training. The primary care is going to be dealing with those who have the most straightforward presentation and management because they have the least training. The CMHA is going to be in the middle. So it allows everyone to practice at the top of their training. And it also then frees up psychiatrists to do initial evaluation, which is arguably the most complicated part. It frees them up to manage the most complicated patients. They have more time to do so. They have more time to teach. They have more time to supervise. They have more time to train because the mild to moderate patients are being seen by CMHAs. So we're going to stop here for a second. And again, turn to you for a question. For some of you, most of you, this is maybe the first time you've ever heard about this. And so I'm wondering your gut response. Who would you expect is going to be the most supportive of this idea and this new profession? Who do you expect is the most hesitant or resistant to this new profession? And you can either unmute or you can type it. But if you're typing it, make sure you clarify supportive or resistant or hesitant. But the one, okay, the second innovation. Sorry, I'm causing all sorts of problems for them. Sorry about that. The second is how we teach and what we teach. Now, this model, I'm going to speak about it with physicians because I know that best, but it's true for nurses and it's true for physician assistants as well. When you come in, you get trained in everything, right? You get trained about all aspects of medicine. The training that a future psychiatrist gets is the same as the training that a future trauma surgeon gets, is basically the same as the training that a future pathologist gets, right? We all get trained in everything. And then you go on to get your specialized training, your fellowship, your residency. After that, you get a much narrower band of training. But when you practice, especially in mental health, you really practice in your specialized knowledge. You're not taking advantage of all those things you learned in general. I used to be able to identify parasites in feces samples, right, under a microscope. I haven't been asked to do that as a psychiatrist, oddly enough. No one has come to me asking for that particular skill set that I learned back in medical school. I don't know the names of the bones of the hand anymore because I even broke my hand a year ago and I don't know which one I broke because it's just one of the bones because it never comes up, right? So you get trained in all of this stuff that you never need. Wouldn't it be more efficient to train folks with the knowledge that they'll actually need and use in their profession? Now, the reason you can't do that in PA school, the reason you can't do that in medicine is because we don't know where they're going to end up. We don't know which medical student is going to be that future trauma surgeon or which is going to be that future psychiatrist. So we don't know which track to put them on. But for CMHAs, we do know. We know what they're going to deal with. They're going to be dealing with mental illness. And so we can focus the training on the anatomy, neuroanatomy, physiology, pathology, and pharmacology that's necessary for identifying and managing mental illness. We can really narrow that focus. It doesn't mean they don't get some general knowledge. Sure, they'll get some, but it's really only the stuff that pertains to mental illness. So let me give you an example. So this is a nice drawing of a kidney. I know this as a psychiatrist because it looks like a kidney bean. And I can think, okay, that's why they named it that way. So what do I know about the kidney? I've been practicing a long time, right? I know that there are lab studies that measure the functioning of the kidney. BUN, creatinine, glomerular filtration rate. I knew I wouldn't be able to say that. GFR, UAs, that measures how the kidney functions. I know that if your kidney stops functioning, it's bad, right? You can get mood disorders, you can get mental disorders, you can get coma, you can get death. It's a bad thing. I know that if I have a patient on lithium, I have to be careful what other medicines they're on, because there are some medicines that will increase lithium level and cause toxicity. There are some medicines that will decrease lithium level and make it ineffective. So I need to be aware of that. And I also need to be aware of the fact that lithium impacts renal functioning, and lithium can damage the kidney. Those are the things I need to know about the kidney. But honestly, that's about it. I don't need to know where those medications are working, whether they're working in the distal tubule or the proximal tubule or the loop of Henle or the Bowman's capsule. I used to know all that stuff, but it doesn't matter. It never comes up. I don't have to be able to identify kidney cells under a microscope. And in fact, those aren't even kidney cells. Those are liver cells, and I don't care, because it's never going to be up to me to decide what those cells are under a microscope. And even as something as important as staging renal failure, is that important? Of course it's important. It's life or death for people, but it's not something as a psychiatrist I'm ever going to be called on to do. A nephrologist is going to do that. Internal medicine is going to do that. That's going to maybe impact how I treat the patient, but they're going to give me that information. I'm not going to be the one who has to learn those different categories and learn what the differences are. So as we focus this training, what that's going to enable us to do is to really spend a lot of time on clinical reasoning skills. How do you think through these patients? How do you take this knowledge that we've taught you and use it to actually provide care? We're going to have lots of clinical vignettes, standardized patients, realistic clinical scenario. We're going to teach and assess on the ability to gather and manipulate information in real time in front of a supervisor. So the patient's going to come in and say, I'm very sad and my stomach hurts. What questions do you ask next? How do you start to develop a differential diagnosis? How do you start to develop a plan to narrow that differential diagnosis? And you have to do that in real time in front of people. But you don't have to do that all by memorization, because you're allowed in real world, you're allowed to have cheat sheets. You're allowed to have clinical practice guidelines and treatment algorithms that walk you through this, that teach you what to do. So if I present a patient and I go through the patient and the CMHA student says, I have my treatment algorithm here and you skipped step 2, we need to get these labs perfect. That's what we're looking for, because you can do that in real medicine. You can have guidelines, you can have things that you rely on. So we're going to teach them about that. Basically, we're going to give a couple hours of lectures in the morning, and then the idea is we bring them in the late afternoon to do interactive stuff, to run through scenarios, to run through classes, to run through examples, to take the information that they've gained and use it. That's the first year. Second year will be clinical supervised experiences, a total of 8 months, inpatient psychiatric units, outpatient mental health clinics, addiction services, with also at least a half a day a week where they get back together virtually to discuss what they've seen, to discuss what presentations surprised them, what presentations were different than they expected, what medications worked differently than what they were told to. Are the places where they're working following the treatment guidelines that they've been trained to follow? If not, why are they changing them? What's going on? So we'll have that opportunity. So if we get this worked out, well, I'll be more positive. When we get this worked out, what would be the biggest advantages to patients, community, and healthcare? And what would be the greatest challenges? Let me, again, stop for just a minute. Anyone want to address either of those? What we see thank you, in a psychiatric practice, because these are true physician extenders, right? By taking up a lot of those patients, maybe not all, but a lot of those patients with mild to moderate illness, it frees up the psychiatrist's time to have more time with the complicated patients, to spend more time doing initial evaluations, to supervise others, to train others. It gives them more freedom. And in primary care, where most of these patients with depression and anxiety are being treated anyway, you're just adding someone who has a lot more training and experience, and they can become the relative expert in that setting. And they're the ones who say, this patient needs to be seen by mental health. This isn't an appropriate one for primary care. Even with me here, we need to to send us on, and they'll have hopefully the background and experience to say that. It's a responsive program in that it's a 2-year program. It's exportable. We've had several universities approach the president's office saying, hey, once you do all the hard work and you get this thing up and running, we want to do it too. We want you to share your curriculum once you have it up there. Only licensed in Ohio. One of the big benefits, though, is because we are creating this, everyone we train has to practice in Ohio. They can't go anywhere else because no state has them yet. Now, we've also had other states reach out to our state legislator people saying, how did you get this through? What does this look like? So it's possible in 5 or 10 years that Utah will have them or Florida will have them or whatever, but we'll have a good head start. And if we can get several universities in the state to graduate a couple, 300 of these folks a year, that's going to make a real impact fairly quickly. Just to let folks know where it was. This idea was passed by the legislature back in December, signed by the governor. It became law. We're working with the medical board, who has established a curriculum advisory panel, one of whom is on the call right now. We have submitted this. We have submitted the master's degree program to the Ohio Department of Higher Education and Higher Learning Commission. We're meeting with them next week about this. We are working on the reimbursement. We're working on malpractice. And if all of the stars align and if everything works out, we would have our first class starting in July of 2026. I'm not a betting man. I'm not sure I would bet the house on that, but that is the goal right now. Okay, so that, last couple things. If you would like to learn more, if you go to NEOMED and type in CMHA, we have a website. And fresh off the presses, just published about a week ago today, actually, or something like that. An article by me on academic psychiatry on the certified mental health assistant, kind of describing some of what we talked about. You'll hear some of the same examples. If you go to academic psychiatry, and this is, you have this link there, it's open access, so you can click on it, download it, read it, print it, whatever you want to do. So that is out there. Let me stop sharing so